Okay, hello to everyone signing on virtually to this session. It is a pleasure to be part of the opening session of COLDA 2020. And while we cannot be in person together, I want to thank the organizing committee for finding creative ways in which we can connect virtually to share the lessons we've learned on preventing, diagnosing, and treating viral hepatitis in Africa. Given the time constraints, I'll be focusing my presentation today on scaling up access to hepatitis C testing and treatment, which is where CHAI has really focused our support over the last few years. And I'll use some examples of countries in the region and compare some of the common elements of success across these countries. So just to provide some context up front, CHAI initiated a viral hepatitis program in 2015, and we're currently supporting ministries of health across 7 countries to scale up hepatitis C treatment, including 2 countries in sub-Saharan Africa, Rwanda and Nigeria. Our approach really focuses at 2 levels. At a global level, we work with governments, drug and diagnostic suppliers, and partners to enable market shaping, which involves gathering and disseminating market intelligence and negotiating significant price reductions for drug and diagnostics commodities. At a country level, we work with ministries and partners to develop and implement the key building blocks of national programs, with an eye towards them scaling naturally as programs mature. Our goal overall is to help countries catalyze rapid HCV treatment scale-up to reach HCV elimination goals. And we've seen firsthand how countries like Rwanda have grown its HCV program from launch, taking really a step-by-step approach, developing optimal strategies to rapidly scale testing and treatment. Fortunately, there have been significant developments in the global HCV landscape over the last 5 years that has made HCV elimination an achievable goal. This slide lays out some of those key highlights. The change in the clinical landscape, for example, has enabled a simplified public health approach for HCV that allows for the simplification and decentralization of HCV services. On the testing front, we have a number of quality assured test kits for screening and multiple lab-based and near point-of-care diagnostic platforms for HCV viral load testing, which allows us to decentralize our case finding and linkage to care strategies. On the treatment front, the use of pangenotypic drugs means that programs no longer need genotype testing, they can eliminate on-treatment viral load monitoring, and that fewer clinical visits are now required for patients. More recently, we're seeing exciting developments in the pediatric treatment landscape and more cross-country collaboration and data sharing to address emerging critical questions in the HCV elimination agenda, like how do lower and middle income countries make decisions on DAA retreatment options without access to highly priced soft Velvox, the WHO recommended regimen. Given these developments, many countries have developed national scale-up plans for viral hepatitis and are scaling up treatment for hepatitis C. With increase in volumes, generic DAA prices have declined significantly, with suppliers offering very low prices to countries committing to rapid scale-up. On the financing side, while we do not have one big donor for fueling a ton of funding into the HCV elimination response, we have seen some progress. Countries like Rwanda, for example, are increasing domestic commitments for HCV elimination. The Global Fund has been increasingly funding HIV co-infection programs and harm reduction services. And Egypt, who is leading the way in HCV elimination, is offering financial and technical assistance for HCV elimination in the region. So really remarkable developments in a very short time. So just to hone in on treatment access from a pricing standpoint, as you can see from the graphic on the slide, there has been significant declines in the pricing for DAAs. Before 2014, pre-DAAs, the price of treatment was over $3,000 per patient course. In 2014, when DAAs came into the picture, innovator access pricing dropped to around $750 per patient course. Currently, with the availability of generic products, the benchmark for DAA pricing has fallen further. For example, the Global Fund and the UNDP procurement mechanisms reference prices as low as $79 to $94 for soft DAC. Finally, Rwanda has been able to secure a $60 per patient treatment course price when the government committed to HCV elimination. And this is now the new benchmark price for a full WHO pre-qualified treatment course. I'll talk in a little bit about Rwanda's experience. It's important that all stakeholders have access to this pricing. And so in May, CHAI released the first ever HCV market report to increase market transparency, to mitigate market barriers, and support progress towards HCV elimination. The report provides a source for HCV market information that is now publicly available, provides information on historical volumes and pricing trends, and suggests potential ways in which countries can access diagnostics and drugs at more affordable prices. So a number of countries in Africa like Egypt, Rwanda, and Nigeria have built upon these global developments to launch and scale HCV testing and treatment. Egypt, Rwanda, and Nigeria are in very different stages of their elimination programs, and the scale of the burden and the epidemic looks very different country by country. So each country is taking a different pathway to scale up testing and treatment. In Nigeria, for example, while the national HCV prevalence rate is around 1.1%, some states like Nasarawa have a much higher burden. And so Nigeria has started with state-wise mobilization of HCV programming, with Nasarawa state leading the way. Rwanda has taken a phased approach to starting with screening amongst people living with HIV and is now rapidly decentralizing services nationwide to reach HCV elimination goals. And Egypt has demonstrated strong political will and commitment and is facilitating mass nationwide screening and treatment scale up. So despite the differences in program scale up, there are common elements that we can draw on from each of these program experiences that can help shape some lessons for other countries in the region. CHAI has partnered with Nigeria and Rwanda since close to the beginning of their programs, and I'll deep dive now into each of these country experiences next. So let's start with Rwanda. Rwanda is a CHAI-supported country that has fast-tracked its commitment to HCV elimination with the target for doing so by 2022. Rwanda has built its program on the principles of simplification, integration, decentralization, and task shifting, and is on track to be the first country in sub-Saharan Africa to eliminate HCV. Rwanda, when developing its program, used a stepwise approach to scale up the national program. Following the introduction of DAAs and development of clinical guidelines, the Ministry of Health, using available resources, started with screening of patients within the ART cohort. Then, using the screening data to highlight high prevalence within the cohort, Rwanda was able to secure some additional resources from the Global Fund for viral load tests and drugs to treat and cure people co-infected with HIV and hepatitis C. Rwanda then expanded its program further to high burden districts and populations. These efforts have now culminated into Rwanda announcing an HCV elimination program and committing to treat over 100,000 patients at the end of 2018. Rwanda has leveraged this commitment to secure competitive pricing for drugs and diagnostics and is now rapidly decentralizing services down to the health center level to meet its HCV elimination targets. In fact, earlier this year, every district in Rwanda has committed to screen over 130,000 people to help the country screen 4 million people by the end of the year, and the country is on track to do so. Overall, Rwanda's experience has demonstrated that political will, with clear planning and evidence-based interventions, starting with high burden populations and leveraging existing infrastructure, along with strong partnerships, are key elements needed for an HCV elimination program. Now, moving on to Nigeria. Nigeria is in an earlier stage of its HCV elimination program, with states like Nasarawa State really forging the pathway for broader national scale-up. As I said before, Nasarawa State has double-digit HCV seroprevalence rates, which is significantly higher than the country average, which is why CHAI initially honed in our support within this state. So once the federal government program was launched, the Nasarawa State Ministry established a state viral hepatitis focal point in 2016 and phased in treatment programs, which focused on, one, expanding diagnostics access through the integration of HCV viral load testing on existing gene expert platforms in the state. Two, scaling up treatment to an initial 10 facilities with a focus on provider-initiated treatment and counseling, which is very critical in a state where patients have to pay out of pocket for their own treatment. And three, Nasarawa State also expanded case finding to primary health facilities, and in the process has been negotiating competitive drug and diagnostics pricing for the program. In 2019, building off these efforts, Nasarawa State government committed to developing an HCV elimination strategy for the region and has developed a 5-year elimination costed plan. This plan helps introduce a line for hepatitis elimination in the 2020 state budget, and it sets the stage for the launch and scale up of services to an estimated 200,000 patients living with HCV in Nasarawa. The elimination plan now leverages a phased approach similar to Rwanda, prioritizing HIV patients by building upon existing service delivery and generating evidence for further program scale up. Nasarawa's experience is demonstrating similar elements to what we're seeing in Rwanda, developing state infrastructure through the integration of services to accelerate access to diagnostics and treatment, and now strategically expanding the program into an elimination program, with the government committing to some initial catalytic funding. So just to conclude this presentation, collective learnings can be drawn from the experiences of countries like Rwanda and Nigeria for other countries who are looking at launching and scaling up public programs. We've seen that countries who are further ahead in their elimination programs have taken a stepwise approach to building evidence of the local disease burden and gathering political commitment by targeting high-risk groups first. They have leveraged opportunities for integration, building upon existing health infrastructure, secured government commitment and political leadership to catalyze the efforts, leveraged current market information to negotiate and secure affordable prices for drugs and diagnostics early in the program, used existing local and international partnerships to support the elimination agenda. And these are elements that are not just common within countries like Rwanda and Nigeria. We've seen these same elements in countries in Asia that we support as well. Maybe just two last comments before I end. While I didn't address HBV in this presentation, it's important to recognize that the elements of strong HCV elimination programs do lay the foundations for expansion of HBV testing and treatment as well. Rwanda, for example, has been including HBV screening within its screening campaigns. Additionally, the availability of effective and affordable HBV vaccines, including the critical birth dose, and the release of the new WHO guidelines to prevent mother-to-child transmission of HBV present the opportunity to integrate HBV services for pregnant women and their newborns as an essential health service, and it presents a clear pathway to achieving an HBV-free generation. In fact, countries in Africa who have strong HIV PMTCT programs can and should build upon these programs to introduce HBV screening and treatment for pregnant women. And finally, we know that many countries are now faced with the unprecedented COVID-19 pandemic and their responses to the pandemic. But we must also ensure that momentum in the scale up for viral hepatitis elimination programs and other health priorities is not lost. In fact, action towards controlling the COVID-19 pandemic can reinforce the fight against other epidemics. For example, COVID-19 investments can be leveraged to expand integrated diagnostics capacity in digital platforms. We've come so far in the last 5 years, and while there's still a number of hurdles countries need to get over to rapidly scale up viral hepatitis programs, countries like Egypt, Rwanda, and Nigeria are demonstrating that these hurdles are not insurmountable. So with that, I will end my presentation here and pass it over to the session chair. Thank you very much.